I'd like to thank the conference organizers for inviting me to discuss these 5 excellent abstracts presented here today. Here are my conflicts. So we'll start out with the background, followed by discussion of 2 abstracts focused on the oral SERD, followed by discussion of a PROTAC abstract, and then a HER3 antibody drug conjugate abstract, and finally a CXCR4 antagonist presenter. And we'll put it all into context at the end. Improved treatments for hormone receptor positive advanced breast cancer are an unmet need. Endocrine therapy and CDK4/6 inhibitor resistance and disease progression develop in nearly all patients receiving these therapies. And unfortunately, post-CDK4/6 inhibitor prognosis is poor. But multiple novel therapies may address hormone-resistant metastatic breast cancer. And here is a table of multiple novel agents and their select ongoing trials, including elacestrant and the EMERALD study, which we heard about earlier this week, and the 2 giredestrant studies, which we'll discuss today, as well as the ARV-471 novel PROTAC study, which we'll also review. Dr. Nick Turner and colleagues present activity and biomarker analyses from a phase 1a/b study of giredestrant with or without palbociclib in patients with estrogen receptor positive, HER2 negative, locally advanced metastatic breast cancer. Dr. Javeri and colleagues had previously presented safety and activity data earlier this year. And they saw activity in patients with detectable ESR1 mutations who had received prior fulvestrant or who had received prior CDK4/6 inhibitors. Today, the authors present updated activity and biomarker data in patients receiving either 30 milligrams of monotherapy or 100 milligrams of giredestrant plus 125 milligrams of palbociclib in combination. Notably, the 30 milligram dose will be the dose moving forward to phase 3, given the bradycardia signal seen with higher dosing. And this is the reason for the discrepancies in the cohorts presented here today. Giredestrant appears clinically active in hormone receptor positive metastatic breast cancer. On the left, in the monotherapy cohort, the overall response rate was 27% with a clinical benefit rate of 54%. And these were patients who had, most of whom had received prior CDK4/6 inhibitors, a number of whom had had prior fulvestrant, and many had ESR1 mutations. On the right, in the combination therapy group, we saw a higher overall response rate of 48% and clinical benefit rate of 81%, but notably these patients had less heavily pretreatment and none had received prior CDK4/6 inhibitor. Many had ESR1 mutations and a few had prior fulvestrant. Giredestrant impacts the ER pathway independent of response or ESR1 mutation status. The authors presented 21 paired biopsies across the 2 cohorts taken at pretreatment and cycle 2, day 8. And they looked at RNA-seq data and immunohistochemistry data evaluating the drug target impact on the estrogen receptor pathway and on estrogen receptor, progesterone receptor, and Ki-67. They saw on-target activity that was independent of the pathway response. And they noted ESR1 mutations detected via circulating tumor DNA as expected, with 40% of patients with at least 1 ESR1 mutation at baseline, but they saw no ESR1 mutations associated with response when looking at serial assessments. Dr. Sarah Hurwitz and colleagues present neoadjuvant giredestrant plus palbociclib versus anastrozole plus palbociclib in postmenopausal women with estrogen receptor positive, HER2 negative, untreated early breast cancer, a primary analysis of the randomized open label phase 2 CUPERA study. This is the primary analysis of the giredestrant versus anastrozole study in postmenopausal women, which was previously presented via interim analysis of 83 patients. The primary endpoint is interesting. Centrally assessed mean relative Ki-67 score change from baseline to week 2, with a target improvement for mean Ki-67 change in 2 weeks of 8%. They randomized 221 patients and had 201 evaluable patients. Patients received either giredestrant or anastrozole for 2 weeks, followed by 16 weeks of neoadjuvant combination together with palbociclib and then surgery. Most patients in the study had stage 2 disease, and most had node-negative disease. Notably, there was a high baseline Ki-67 with 37% in the giredestrant arm and 42% in the anastrozole arm. The study met its primary endpoint of reduction in Ki-67 with a relative reduction in giredestrant of 75% and anastrozole of 67%, and just missed the threshold for success of 8%. It was overall well tolerated with one grade 3/4 adverse event of uterine perforation that was unrelated to study drug and one episode of bradycardia. But what does an 8% drop in Ki-67 really mean? The benefits of Ki-67 include its cost, its low cost and accessibility, but challenges is that the most dominant challenge is the reproducibility. And this has been addressed by the International Ki-67 in Breast Cancer Working Group, and who had an update late last year, noting that the early change in Ki-67 could be helpful to determine if the patient is likely to benefit from their current therapy, but also noted that a Ki-67 between 5 and 30% are very difficult to interpret given inter-observer variability, and begs the question, is this data presented here strong enough evidence to support a phase 3 adjuvant study as is planned? And giredestrant takeaways that it appears very active in hormone receptor positive HER2 negative breast cancer previously treated and in early breast cancer. It appears well tolerated and without worrisome safety signal despite the prior data. Given the challenges in Ki-67 reproducibility, the meaning of an 8% reduction in Ki-67 is unclear. ESR1 mutation detection and tracking via circulating tumor DNA in metastatic breast cancer is of interest, but the limited numbers make the interpretation of the clinical meaning of serial testing difficult. Further development includes the ongoing phase 3 first-line metastatic trial and the adjuvant trial. And this all begs the question of how will elacestrant data impact this very busy space. Dr. Hamilton and colleagues present the first-in-human studies of safety and activity of ARV-471, a novel PROTAC estrogen receptor degrader in ER-positive, HER2-negative, advanced or metastatic breast cancer. PROTACs, or proteolysis targeting chimeras, are small molecules with 3 chemical elements: a target protein binding ligand, an E3 ubiquitin ligase binding ligand, and a conjugating linker. And PROTACs really elegantly take advantage of the endogenous ubiquitin proteasome system, with ARV-471 specifically targeting the estrogen receptor. On the right is a graphic illustration of how these work. First, complex formation. The PROTAC, and specifically the target protein binding ligand, recognizes the ER in this case and binds it. In number 2, the protein tagging. So once bound, the E3 ubiquitin ligase binding ligand tags the ER with ubiquitin, which then identifies it for 3, protein elimination, a protein elimination via the proteasome, leading to degraded estrogen receptor. So the authors conducted a 3x3 phase 1 dose escalation study of 60 patients, and patients received daily oral doses ranging from 30 to 700 milligrams. So it's a heavily pretreated population with 100% receiving prior CDK4/6 inhibitors, 80% receiving prior fulvestrant, and 78% receiving prior chemotherapy. In terms of safety, it was very well tolerated with no grade 4 toxicity, low grade 3 toxicity, and no bradycardia events. In terms of efficacy, the clinical benefit rate was 40% in 47 evaluable patients, and so responses were seen in patients with prior CDK4/6 inhibitors, prior fulvestrant, prior SERDs, including oral SERDs, and 2 PRs were seen in heavily pretreated patients, including one who had received an investigational SERD. So ARV-471 is a novel drug in a novel drug class targeting ER, and with phase 1 data showing activity in pretreated patients, including those with prior SERD and with minimal toxicity. It asked the question, could this drug be used post-SERD, which could be very helpful in this busy space? And next steps include a phase 2, the VERITAC cohort, a phase 1b in combination with palbociclib, and a phase 3 study is planned. Dr. Pratt and colleagues present activity of patritumab deruxtecan, a HER3-directed antibody drug conjugate in early breast cancer and ERBB3 expression, and interim analysis results of a window of opportunity study, the TOT HER3 study. Patritumab deruxtecan is a HER3-directed ADC with prior demonstrated activity in metastatic breast cancer that was independent of HER3 expression. And TOT HER3 is a window of opportunity study designed to assess the increases in immune infiltration via the cell TIL score during preoperative treatment. Primary objective is to evaluate the change in the cell TIL score after one dose of patritumab deruxtecan in paired baseline and post-treatment samples. And the authors present the planned interim safety and efficacy data on the first 30 patients. What is a cell TIL score? So a cell TIL score is on-treatment quantitative measure based on the percentage of cellularity in stromal tumor infiltrating lymphocytes. Cell TIL was initially tested in the PAMELA study via a day 15 biopsy, where that day 15 biopsy result was shown to be prognostic. Cell TIL early in neoadjuvant therapy predicts pathologic complete response across breast cancer subtypes and therapies, and is prognostic for EFS and OS in HER2-positive breast cancer specifically. Notably, it has not been tested in terms of prognosis in other disease subtypes. The intention to treat population here was 29 patients with hormone receptor positive HER2-negative breast cancer, any HER3 status. 70% of patients had no negative disease with a median Ki-67 of 30%. And 63% of patients were premenopausal. Patients had a baseline biopsy or archival tissue assessed, followed by determination of ERBB3 status via RNA-seq, followed by one dose of HER3 deruxtecan and a cycle 1 day 21 biopsy. That was the primary endpoint or assessment of cell TIL with clinical evaluation of the tumor response by gauge or ruler. Again, notably, the biopsy was at day 21, which is different than the initially done biopsy in PAMELA of day 15. The cell TIL score increased significantly after the single dose of patritumab deruxtecan that was independent of HER3 status. The authors noted that the cell TIL score increased specifically in clinical responders, as shown on the right. In terms of safety, 75% of adverse events were grade 1 and 23% were grade 2. There was one grade 3 reversible treatment-related ALT increase that was reported. In terms of responses, there were 20.8% of patients with a partial clinical response, 25% of patients with complete clinical response, and any clinical response by palpation was 45.8% after one dose of the drug. So in takeaway, future directions for patritumab deruxtecan include an ongoing 2-part phase 2 study in HER2-negative metastatic breast cancer evaluating for predictive biomarkers, as well as potential further study in the neoadjuvant setting. In terms of the cell TIL score, it was associated with clinical response, not associated with HER3 status. Notably, it's not previously been validated as a prognostic marker outside of HER2-positive breast cancer, making this particular analysis interesting. A high cell TIL post-treatment score was associated with the PAM50 ROR high score. And this is also an interesting point and asks the question, what does this mean given the contradictory prognostic value of these two results? And finally, how do we choose robust enough biomarkers for window studies is an important question raised by this study as well as the previously presented SERD study. finally, Balixafortide, a CXCR4 antagonist plus eribulin versus eribulin alone in patients with HER2-negative recurrent or metastatic breast cancer, an international randomized phase 3 trial, the Fortress study, presented by Dr. Peter Kaufman and colleagues. CXCR4 SDF1 alpha axis regulates immune cell function and trafficking and the tumor microenvironment. And Balixafortide is a selective CXCR4 antagonist that mobilizes tumor cells out of the metastatic niche and into the peripheral blood, thereby increasing the susceptibility to eribulin. Preclinical data in mouse models showed superior outcomes with the Balixafortide agonist and eribulin compared to eribulin alone in murine breast cancer models. There are promising phase 1b safety and efficacy data shown on the right here from Dr. Parsons and colleagues that were previously reported in patients with HER2-negative metastatic breast cancer, leading to this phase 3 study. And Dr. Kaufman and colleagues conducted the phase 3 trial, randomizing patients with advanced HER2-negative breast cancer to Balixafortide plus eribulin versus eribulin alone in the study presented here today. The authors randomized 432 patients to Balixafortide versus eribulin, together with eribulin versus eribulin alone, and saw no difference in progression-free survival or overall survival, with more than 50% of events reporting. There's a notable safety profile that was similar to the prior phase 1 study, showing higher rates of infusion-related reactions, pruritus, rash, and erythema in the Balixafortide arm, and numerically higher rates, though low, of pulmonary embolism. All of these were asymptomatic. But putting Balixafortide in context, why was the phase 3 result so different from the phase 1 study? Looking at the patient population, asking, can we gather some information about why these results might have been so different? We're showing here the Fortress Balixafortide and eribulin arm on the left column and the phase 1 study on the right column. The Fortress study had a higher proportion of patients with triple-negative breast cancer, 36% versus 23%. And in terms of extent of disease, 86% of patients in the Fortress study had visceral disease versus 71% of patients in the phase 1 study had at least 2 organs involved. The Fortress study patients were less heavily pretreated, with 22% having had at least 3 lines of therapy versus 70%. Taxane use was similar, and prior anthracycline use was higher in the Fortress study, perhaps related to the higher numbers of patients with triple-negative disease. And so despite very promising phase 1 data, the randomized phase 3 Fortress study was negative, and additional subgroup analyses revealed no subgroups receiving benefit. So putting it all into context, these abstracts have shown that there are multiple promising agents and multiple classes in development for HER2-negative breast cancer, including SERDs, PROTACs, and antibody drug conjugates, but also hopefully that predictive biomarker development is challenging but essential to rational drug development and state-of-the-art patient care in the age of multiple available therapies. So thank you and congratulations to the presenters and to their colleagues. Thank you to my co-discussant, Dr. Oliveira, and to session chair, Dr. Tolaney. A special thank you to Drs. Hal Burstein, Erica Hamilton, Ian Kropp, and Nancy Lynn for their help in developing this presentation and for their kind contribution of slides. Have a wonderful day.